Welcome back, everyone. Today, we're going to spend our entire session focusing on one of the most common and clinically important groups of injuries in hand trauma, fractures of the metacarpals and phalanges. At first glance, these may seem straightforward. After all, the bones are small, the injury's frequent, and splinting is common practice. But as we'll see, the anatomy and biomechanics of the hand turn even a simple fracture into a potential threat to fine motor function, grip strength, and long-term quality of life. So let's take this page as our roadmap. We'll move step by step from the general features of metacarpal fractures to the peculiarities of the thumb base injuries, the famous Bennett and Rolando fractures, and finally to the phalangeal fractures, where correct alignment means everything. Along the way, we'll tie anatomy to mechanism, clinical exam to imaging, and surgical strategy to functional outcomes. First, look at the illustrations of metacarpal shaft fractures. Notice how the transverse fracture of the shaft tends to angulate dorsally. Why? Because of the pull of the interosseous muscles. These muscles insert onto the bases of the proximal phalanges and extensor expansions. Their natural resting tone creates a dorsal displacement force whenever the shaft loses continuity. This is why even a simple transverse fracture often results in a visible dorsal bump when you inspect the hand. Next, consider fractures at the metacarpal neck. These are common, particularly in the fifth metacarpal, producing the well-known boxer's fracture. The volar cortex often shatters into small fragments, leading to comminution. After closed reduction, instability is frequent because that volar buttress has been lost, which is why many of these injuries require pinning to maintain alignment. Clinically, always remember that the ring and little finger metacarpals tolerate more angulation, sometimes up to 40 to 50 degrees, because of their mobility at the carpo-metacarpal joints. But the second and third metacarpals are rigidly fixed and cannot tolerate such deformity. Now, the oblique fractures of the metacarpals. These carry their own biomechanical problem. The obliquity allows for shortening and rotation. This is especially true in the index and little fingers, where independent movement is crucial. Middle and ring finger metacarpals, stabilized by strong transverse metacarpal ligaments, are less likely to displace. The clinical pearl here, shortening of even a few millimeters or subtle malrotation can dramatically impair finger alignment. When you ask the patient to flex their fingers into a fist, the fingertips should all converge toward the scaphoid tuberosity. If one finger scissors across its neighbor, that is malrotation. And malrotation is never acceptable. Unlike angulation, which can sometimes be tolerated, rotational deformity must always be corrected. Now, let's shift our attention to the thumb, and in particular, the fractures at the base of the first metacarpal. These are not just fractures, they are instability patterns that can devastate hand function if mismanaged. The first is the Bennett fracture. This is an intra-articular fracture with a triangular fragment of bone remaining attached to the trapezium by the anterior oblique ligament. Meanwhile, the larger metacarpal shaft is displaced proximally and radially by the strong pull of the abductor pollicis longus tendon. This creates a fracture dislocation situation. The base fragment is stable, but the shaft fragment rides away. For that reason, Bennett fractures cannot simply be immobilized. They require reduction, often percutaneous pinning, and sometimes open fixation to restore congruity of the carpo-metacarpal joint. Left untreated, they reliably progress to painful arthritis. The second is the Rolando fracture. This is the more complex cousin, an intra-articular fracture with a Y-shaped configuration, often comminuted. Unlike Bennett fractures, where reduction is achievable, Rolando fractures tend to shatter the base of the metacarpal, making stable fixation very difficult. They are highly unstable and have a poor prognosis, with a high risk of post-traumatic osteoarthritis. When you hear Rolando fracture, think of an injury that almost always requires open reduction and internal fixation, and even then, long-term pain and stiffness are common. A clinical pearl. Whenever you evaluate thumb-based fractures,
always assess for grip strength and pinch strength. Patients may lose the ability to hold objects firmly between thumb and index finger, which is functionally devastating. Radiographically, stress views or CT scans can clarify the degree of intra-articular involvement. Now let us consider the proximal phalanx fractures. Look at the illustration of the fists. In a normal hand, when the fingers flex, the tips converge toward the scaphoid tuberosity. This elegant convergence is the result of precise alignment of phalanxes and metacarpals. When a fracture of a phalanx or metacarpal heals in malrotation, the finger will overlap its neighbor in flexion. Even a small degree of malrotation translates to large functional impairment. For example, a 5-degree malrotation at the metacarpal level can cause up to 1.5 centimeters of overlap at the fingertip. That means the patient cannot make a straight fist, cannot grip, and may even suffer painful scissoring of the digits. Reduction of phalangeal fractures, therefore, must restore not only longitudinal alignment, but also rotational alignment. This is why surgeons always check the hand in a clenched fist after reduction. Unlike angulation, which can be compensated in some fingers, rotation is unforgiving. Another important point: stiffness. Phalanxes are unforgiving bones when immobilized too long. Even with proper reduction, excessive immobilization leads to adhesions of the extensor tendons and loss of range of motion. Early mobilization, when safe, is just as important as fixation. Now let's tie it together using the chart at the bottom of the page. Description: most metacarpal fractures occur in adults, usually from a fall or a punching mechanism. The 5th metacarpal neck fracture, the boxer's fracture, is by far the most common. Thumb-base fractures are particularly problematic because of their intra-articular nature. History: it will include trauma, pain, swelling, and deformity. On physical exam, always assess for rotational alignment, angulation, and neurovascular status. Radiographs, especially oblique views, are key, while CT is invaluable for complex intra-articular fractures. Classification: fractures are classified by location: head, neck, shaft, or base. Shaft fractures can be transverse, spiral, or oblique. Thumb-base fractures divide into Bennett, Rolando, or the so-called baby Bennett in the small finger. In treatment, stable, non-displaced fractures can often be managed with casting. Displaced but stable fractures may require reduction and immobilization. Unstable fractures demand percutaneous pinning or open reduction and internal fixation. Importantly, Bennett fractures usually require surgical fixation. Rolando fractures almost always require it. And don't forget the complications: malunion, non-union, grip strength deficiency, and post-traumatic osteoarthritis, especially in Rolando fractures. So, to summarize, metacarpal and phalanx fractures are not minor injuries. They demand respect for the anatomy, a meticulous physical exam to rule out rotation, and careful imaging to detect articular involvement. Remember, angulation may sometimes be tolerated, but rotation never. Bennett fractures require fixation to restore joint congruity, Rolando fractures are complex and prone to arthritis, and phalanx fractures demand precise alignment and early mobilization. If you take only one thing from today's lecture, it is this: in the hand, small details make enormous differences. A millimeter of displacement, a few degrees of malrotation, or a fragment left unreduced can mean the difference between a hand that functions and a hand that fails.
Phalangeal fractures are among the most common injuries of the hand. They occur in all age groups, and the mechanisms are often surprisingly mundane: jamming the finger in a bore, twisting during sports, or direct crush injuries at work. Yet, despite their frequency, these fractures can be deceptively complex. Why? Because the phalanges are slender, surrounded tightly by tendons, pulleys, and joint capsules. Even a small step-off or malalignment can compromise the intricate mechanics of flexion and extension. Another key principle: stiffness. Unlike the metacarpals, where angulation may sometimes be tolerated, phalangeal fractures punish immobilization. Early motion is critical to avoid adhesions and permanent range of motion loss. That's why in hand trauma, treatment isn't just about bone healing, it's about preserving tendon gliding and joint mobility. Extra-articular shaft fractures. First, look at the oblique shaft fracture illustration. Extra-articular shaft fractures can be transverse, oblique, or spiral. Oblique fractures are particularly unstable, prone to shortening and rotation. Remember, just as in the metacarpals, rotational deformity is never acceptable. Always check the patient's finger cascade. When they flex, the fingertips should all point toward the scaphoid tuberosity. If one finger crosses its neighbor, you're looking at malrotation, and that requires surgical correction. Intra-articular base fractures. Now examine the intra-articular phalangeal base fracture. If non-displaced and stable, we can treat conservatively with buddy taping and early motion. But displacement within the articular surface is dangerous. It sets the stage for early osteoarthritis. Therefore, intra-articular step-offs greater than 1 to 2 millimeters usually require open reduction and internal fixation to restore the joint surface. Condylar fractures. Next, the condylar fractures. These involve just one of the articular condyles of the phalanx. They are inherently unstable because the intact condyle acts as a lever, displacing the fracture fragment. In children, they may mimic growth plate injuries. If untreated, they produce angular deformities and joint incongruity, so operative fixation is typically needed. Fractured dislocation of the middle phalanx. Now, look at the fractured dislocation of the middle phalanx. These are tricky injuries. The fracture compromises the articular base, and at the same time, the joint subluxes or dislocates dorsally. Simply reducing the dislocation will not hold because the bony buttress is lost. That's where the extension block splint comes into play. By blocking full extension while allowing some flexion, the splint maintains joint reduction until the fracture heals. If instability persists, surgical fixation may be required. Distal phalanx fractures. Finally, the distal phalanx fractures, which we see every day in practice. 4 main types are illustrated. Longitudinal, or A, often stable, sometimes managed conservatively. Non-displaced transverse, or B, usually splinted, good prognosis. Angulated transverse, or C, often unstable, may require reduction. Comminuted, especially common with crush injuries, often involving the nail bed. These are the so-called tuft fractures, frequently associated with nail bed lacerations. Management isn't just about the bone, it's about repairing the soft tissue. You must irrigate the wound, repair the nail bed if necessary, and protect the distal phalanx with a splint. If you miss the nail bed injury, the patient may end up with painful nail deformities long after the bone is healed.
Let's reinforce the clinical approach. History. Look for trauma mechanism. Jamming, twisting, crushing. Physical exam. Pain, swelling, deformity. Most importantly, check for rotational alignment. Ask the patient to flex into a fist. A single scissoring finger is diagnostic of malrotation. Neurovascular exam, especially important in crush injuries. X-rays. Always get multiple views, including obliques. Pay attention to step-offs at the joint surface. CT scans, reserved for complex intra-articular patterns where plain films don't show enough detail. We classify phalangeal fractures by extra versus intra-articular, displaced versus non-displaced, fracture pattern, transverse, spiral, oblique, location, condyle, neck, shaft, base, tuft. Treatment principles followed this framework. Extra-articular stable fractures, buddy taping, splinting, and early mobilization. Unstable extra-articular fractures, closed reduction and pinning, sometimes ORIF. Intra-articular fractures generally require ORIF to restore the joint surface. Middle phalanx volar base fractures, extension block splint if stable, ORIF if unstable. Tuft fractures, irrigate, repair nail bed, splint. The recurring theme is that early motion is essential. Immobilize too long and the hand stiffens. Mobilize too early and the fracture displaces. Balancing those forces is the art of hand trauma management. What are the major complications to remember? Stiffness, the single most common and disabling issue. Prevent with early motion and hand therapy. Loss of range of motion, especially after intra-articular injuries. Non-union or malunion, rare in phalanges but functionally catastrophic when they occur. Osteoarthritis, particularly after condylar and intra-articular base fractures. Nail deformities, following tuft fractures with missed nail bed repair. So always think function first, fracture second. The ultimate goal is not just to heal bone, but to restore a hand capable of fine movement, precision grip, and strength. And that brings us to the end of phalangeal fractures. As we've seen, the hand demands respect. Small bones, but massive consequences when mismanaged. Always remember, check alignment in a fist. Never accept rotation. Restore the joint surface whenever intra-articular involvement is present. Protect tendon gliding and motion above all. If you can integrate these principles into your surgical thinking, you'll not only treat fractures, you'll preserve hands, livelihoods, and quality of life.